I was asked to sort of make sure that we do a little bit of level setting. While most of you, I think, are probably very familiar with the term social determinants of health. Certainly you've seen a lot of data that actually falls very nicely under the category of social determinants of health, but I think I want to do a really, really quick review, mostly just so that for those of you who don't know or are not entirely sure why we're going to be talking about things like transportation and that sort of thing, what we mean when we say social determinants of health. So we'll start with what do we know? What do we know about health in the United States? What we can tell quite clearly, let's see if I can do this with this hand, is that the United States is not getting its money's worth in terms of how much we spend. We have overall our health outcomes, if you use the most gross version of health outcome, which is life expectancy, we're not getting very much for the massive amounts of money that we spend. We also know that health isn't evenly distributed throughout the United States, and one of the most important ways in which it's not distributed is in the outcomes if you look at race. And again, this is life expectancy, a fairly gross overall indicator of health, and yet we see pretty significant disparities in overall nationwide life expectancy by race. So what is it that makes this happen? Why do we see this? And we start up here. These are the health outcomes that we typically and historically have been monitoring forever and ever. So mortality, how long do we live, morbidity, how much disease do we have? And for the first, for the last 50 years or so, that's pretty much been what the conversation was about until fairly recently. But we also kind of need, I work in the world of public health. Our job is to intervene to try to lengthen life and decrease the amount of morbidity. So we need to know, in order to do that, to design interventions, what are the factors that cause health or engender health or cause disability, et cetera. And so when we look now at a lot of data, this is how the conversation has begun to change. When I was first started in public health, the only conversation we really had was about access to care. We've got to get people medical care. If we get people medical care, we can even out all the problems. The disparities that we see in health really are due to clinical care. So both access to care, but also quality of care. And so we were working really hard on that. Well, it turns out, as hard as you work on that, you really can only achieve between, depending on whose numbers you want to use, 10 to 20% improvement overall in health. That's what clinical care contributes. Now, it's essential, absolutely essential, 10 to 20%, but that's not the whole picture clearly. So then public health steps up and says, well, of course, because we already know it's all the bad behaviors that we all engage in. Right? It's all about behavior. We've got a pamphlet for everything. Pile all those pamphlets on top of each other. You could go from here to the moon, no problem, probably back again. And if anybody knows of a pamphlet that ever changed behavior, please let me know. So really, and health behaviors, or risk behaviors as we call them, account for only about 30%, in fact. Even if you take tobacco use, diet and exercise, alcohol, sexual activity, et cetera, high-risk behaviors, again, depending on whose numbers you want to use, between 30 and 40%. So the conversation for 50 years was, at most, covering 60% of the issue. So some smart people, like many of the people in the audience here, started thinking about what else is there in the picture, because clearly this ain't it. And let me tell you, it was not easy to make that case initially. Now it's like a giant duh. If you go talk to young people in public health school, it's like, well, of course, we knew that. Well, we only just recently knew that, I'm here to tell you. But what those things are, and some of them you've already seen talked about today, are both social and economic factors, and then factors having to do with the physical environment in which you exist, in which you live, work, play. Things like education, employment, income, family and social support, community support. These are measurable factors, and that's the point, given that this is a data place, measurable differences in health outcomes based on these. And in the physical environment, something we call the built environment, which is the structures around you in which you live and how well they function and engender or not health. And then environmental quality as well. So those are, and so in order to really impact the health factors and therefore health outcomes, we actually have to work on the whole thing. And so we're talking here 20 to 50% for those underlying determinants of health. And it's policies and programs that are designed to impact all of these that will ultimately get us where we want to be, which is optimizing health. One word about behavioral risk factors. It makes me crazy when people talk about, I got asked by a legislator to tell me, what am I going to do about the obesity epidemic? How am I going to make people make the right choices? Well, a really important fact is that people's behavior, their choices are shaped by their lives and by the opportunities they have. And I hope to show you a couple of slides to demonstrate that in case you don't believe it. Yes, there is personal responsibility. There absolutely is. I know because I've been eating a lot of chocolate recently and I'm not sure why. But it's definitely on me that I'm doing that. So yes, we each have responsibility, but that isn't the whole story. Again, there's a lot else that goes into that. What's your choice for eating healthy if this is the only grocery store within 3 bus rides of you? Versus if you, like me, have a whole paycheck grocery store in your neighborhood. Or if these are the images that you see all day, every day when you're growing up, and these become your norm. So yeah, you're making choices, but you're making choices to approach, as most of us do, our social norms. And similarly, who chooses to live in a neighborhood like this versus one like this? Everybody who can. This guy, who you probably almost can't see, didn't really have a choice to live here. This is where he grew up. So it's really important that we keep, once again, this is preaching to the choir, but keeping these factors in mind really impacts how we do our jobs every single day. Because these things, these differences between this neighbor, oops, that was probably a mistake, huh? Okay. Between one neighborhood and the other, there's nothing natural about those differences. They did not occur in nature. They occurred in the setting of the same system that says that these things are located next to certain communities and not next to other communities. And that is the society and the institutions in our society. There's institutional power at work that help create the distinctions that we have between neighborhoods and between people. You'd be astonished at how recently some of these kinds of local ordinances continued to stay on the books. So, summarizing, conditions in the social, physical, and economic environment in which people are born, live, work, and age. They are the policies, the programs, and the institutions, as well as other aspects of our social structure, including government, yours truly, and private sector, as well as community factors. That's what we're talking about when we talk about the social determinants of health. One other concept I would like to put out, we talk a lot about health disparities. Disparities are differences between numbers. That's not what we want to achieve. I don't actually want to achieve no disparities. What I want to achieve is health equity, and that's the highest level of health for everyone in the community. Everybody should have the same opportunity to make the choices that allow them to live a long, healthy life, regardless of the conditions in which they live. Okay, so what this means for you as data folks is that we used to just need these were the ways that we measured health. Now we need all this data too. And what do we do with that data? Well, this is, if you have just a birth certificate database, which, by the way, isn't as easy to create as you would think. So you can ask Dr. Green over there what it takes to actually create the birth data file. But this is an example of some data that's in Let's Get Healthy California on our website that's easily approachable. All of these factors, though, are listed on a single data source, so it makes something like this quite easy. But what we've needed a lot to start to address social determinants of health are these other tools. We need access to other sources of data. Obviously, if I want to know about the conditions in a neighborhood, particularly something like the physical environment, I don't have that data in health. And geocoding as well. I'll show you some data that was put together 10 years ago, almost exactly, by one of our colleagues in Alameda County, Dr. Tony Aiton. He had the novel idea that if he looked at all the services that were being provided by the government, the local government, it might tell him something about the community. So they They looked at social services. These are by census tract with increasing numbers. They looked where were parolees getting information, where were probationers getting services, to come up, and with public health data, et cetera, to come up with a composite of how many services are being given to people and in which census tracts. This was, at the time, really revolutionary, partly because he had to go to each of those departments independently and try to get them to give him information. And that took almost 3 years to put this together, with what arguably is not terribly complicated data. But what we learned from it was that there were 13 census tracts where the overwhelming majority of services were being provided. And it turns out, long story short, that guess what? Those are also the census tract with the greatest poverty. And if you start to look more carefully at these neighborhoods, in the green areas, the neighborhoods with the best outcomes, you'll notice that high school graduation, so educational attainment is higher, unemployment is lower, poverty is lower, home ownership is higher, and yes, there are fewer non-white people. So the middle level of for life expectancy in these neighborhoods, again, now what we see, high school, a little bit less, unemployment a little bit higher, poverty a little bit higher, home ownership a little bit lower, and many more non-white residents. And then finally, in these very high-risk, poor outcome neighborhoods, again, the environment is different. High school graduation rates now are very low, unemployment's very high, poverty's extremely high, home ownership very low, and non-white populations, demonstrating finally and very clearly on a neighborhood level that there are very substantial and measurable impacts on life expectancy. Oakland Flats, low-income area, Oakland Hills, high-income areas, and not just for some races, but for all races, including whites. If you look at the difference in outcome, it's really not as much about your race as about where you live and all those cumulative factors. And you can plot it for a lot of other things. So that's the beauty of big data or open data and GIS. I just want to talk just a little bit about how we measure. I know I'm over time, but we started late. Cut me some slack. So in 2012, the governor released an executive order requiring the Secretary Dooley to convene experts from around the state to answer two questions. What would it look like if California was the healthiest state in the nation? And what would it take for that to happen in 10 years? So what they came up with is what's known as Let's Get Healthy California. This was founded in the Triple Aim. They reviewed a lot. Actually, this is just an example of really well-accepted indicators, data points for health and health outcomes. These informed a set of priorities, goals, and targets, and across the whole thing was that concept, once again, of health equity. So focusing on health equity as the desired outcome. Everybody has an equal opportunity to be healthy. The report was issued in December of 2012. There are two key strategies. One is to measure health across the lifespan. The second is to improve the way we deliver health and healthcare by different pathways. And you'll see these are the 6 goal areas that are in which there are indicators, up to 39 indicators with 10-year targets. The clock is ticking. That means 2022, and we have a ways to go. I just want to show you the 3 key core components you'll see on the website. You're going to get an opportunity to mess about with the website in a little bit, so I'm just going to give you an overview. There's a lot of, you'll see the data and the visualization of data, but also meaning of the data. Why do you care? Why should you care? We also have promising interventions. Who's out there working to move the needle, and a lot of opportunities for stakeholders to engage. And you'll notice again, public reporting and collaborative engagement are 2 key pieces in Let's Get Healthy. This is what the website looks like. This is the landing page where you'll see a little video if you'd like. Goals and priorities are listed. And then within a goal, there are priorities for each of the goals. and opportunities to get involved. If you go to the Healthy Beginnings goal landing page, you'll see priorities within that, so vaccinations, childhood trauma, et cetera. And this is an indicator, one of the indicators, infant mortality. You'll see the data presented in a variety of ways, depending on the data and its source. And wherever possible, which is true, most places you'll have interactive maps where you can click on it to look at various communities. And I think, and a lot of information about who's working on what in this area and opportunities to become engaged. The goal is not just to talk to people who are already working, but also the general public as well, and other organizations that feel that improving health in their community is important. In January, we had the Innovations Conference. We had over 100 innovative approaches to various goal areas. You can find them all on the website, but more importantly, today you're going to get to hear 3 of my colleagues talk about them. So I'm going to cede the stage to them. Matt Willis, Dr. Willis is the health officer for Marin County, and is going to talk about RX Safe Marin. And then Debra Oto-Kent is our real community representative, non-governmental representative. She's the executive director for the Health Education Council. Is going to talk about Walk with Friends, a very successful program in her area. And Dr. Handler is the local health officer for Orange County, who's going to talk about WasteNotOC. So Matt, you want to take it over? And I think we have to switch over.
Good afternoon. So I'm Matt Willis, Public Health Officer for Marin County. It's wonderful having a health officer that is, for the state, that is so interested and eager in helping us understand the role of government in structural inequities, and is willing to engage in dialogue around dismantling some of those structures. So thank you, Karen. I met Karen in Haiti, in Port-au-Prince, after the earthquake. I was down there working as an epidemiologist with the CDC, and she was working, trying to control malaria spread, I think, in the tent camps. So we go back a few years. Yep.
All right, here we are.
So I have a slide presentation that will come up shortly on our effort in Marin County to address the problem of prescription drug misuse and abuse. 2 years ago, we decided that this was an issue that we would determine as a formal public health priority for us. I put out a public health advisory to our community. It's a forum that I would normally use for outbreaks and things that were kind of relevant and urgent for our provider community. But we actually issued a call to action around the problem of prescription drug abuse as an epidemic. Dr. Frieden at the CDC had declared prescription drug abuse as an epidemic. Dr. Smith has also used that term for the state, and we've used that appropriately at the local level as well. So I'm going to talk to you a little bit about just how we're using data to address this epidemic locally for our coalition. Okay, so this was 2 years ago. We issued an open invitation to everyone in the community with a very open question to join us. What can we do as a community to prevent prescription drug misuse and abuse and save lives? And we used flyers and phone calls and old school, just kind of recruiting people to join, not knowing how many would come, hoping that some at least might come to join us. The meeting did start at 7:15 in the morning, and we had about 100 people there. Fortunately, we had the foresight to have a barista available, so we had coffee. But it was clear that we had hit a nerve, that we were on something that the community was really interested in. And we had partners from law enforcement and schools and healthcare systems, elected officials, all there. And we recognized, this being a complex social problem and not just a problem of healthcare, that we were going to need to be addressing multiple sectors at once, including prevention and education, surveillance and monitoring, diversion control, law enforcement, and treatment and recovery. So achieve goals in all of those areas. Out of that meeting, where we kind of started towards a 3-year strategic plan for RX Safe Marin, we sorted ourselves into 5 different action teams that represented the different sectors who were there. And what's interesting, I think, maybe for this group, is that one of the action teams was actually specifically dedicated to data. Because what we found is that the other action teams, which are community-based prevention, law enforcement, the prescribers and pharmacists, or the healthcare team, and then the treatment and recovery team, didn't have the information they needed to design the strategies effectively. And so it kept coming up that in those teams, they were like, well, how do we know what to be working on? And we suddenly said, you know what, we just need a whole team dedicated to acquisition of data, because this problem was not well enough described. So this was one of the goals for the action team. Each of the action teams had SMART goals, specific, measurable, et cetera. And the data action team developed a SMART goal that was based on the problem that we were seeing an epidemic that had no surveillance system. Right, so this is an epidemic. Normally in public health, when we have an epidemic, we sort of know what we're measuring. Like tuberculosis or HIV. We measure the crap out of things we care about. Those of you in HIV, there's a lot of measurement that goes on. And here was an epidemic where we were seeing, a death in Marin County every 2 weeks from an accidental overdose, 250,000 total people. Each of those, and it's a tight community, so each of those really had a strong effect through the whole community. But we didn't have an inherited surveillance system for actually measuring this issue. So we thought we needed to build something kind of locally and working with others who were trying to struggle with the same issue. So this was our goal. We wanted a report card or a dashboard, and we wanted to engage the community in selection of indicators of the greatest relevance. So that was another factor. We actually wanted the community to decide what we should be measuring. So these were the steps that we chose towards developing our report card. We consulted with federal, state, and other local jurisdictions. We contacted local agencies to determine the availability of county-specific data, so local data. We reached out to Los Angeles County, and I think, Dale, you're here with San Diego County, and they had done some work around their own report card. And then we compiled the data to present potential indicators to community members, so people that may not be that data savvy, but might have an idea of what we should be measuring. And that process involved sort of a statement of why would this data element matter, what the results of that data element were, and then what the source was. And then people actually voted on which indicators to include on the report card. So these are some of the partners that we looked to. So as I said, San Diego County was a little bit ahead of the curve here, and we are happy to plagiarize from one another, liberate content across the way. Also, the Department of Justice was very helpful in sharing data from the CURES system, which is the prescription drug monitoring program for the state. It has all of the prescriptions for controlled substances statewide. And then other progressive counties and states around the nation. So this is just an example of the way in which we presented potential data elements to our community partners for the voting process. So this was one, the emergency department visits for opioid-related ED visits. We have why this matters. There are the results over time, and then the source. And in the end of that process, we ended up with 7 different data sources for 10 different report card elements. And these are the data sources. So some came from the state, OSHPA data, CURES data, vital statistics, and CalOHMS. And then local data, we partnered with the district attorney for drug possessions, our environmental health services, and the DEA for the number of the raw pounds of safely disposed medications, and then our EMS for naloxone doses administered. So this is what our report card, so I was very excited about that. We had done this amazing job of getting all these report card elements together. And then this was kind of what it ended up looking like, and it sort of felt anticlimactic. It's, there it is. So it's like, it's got to be, it's not enough just to have the data. Like, we really were hoping for this to be sort of a catalyst for this movement within the county to address this problem. And it just didn't seem to have the oomph that we needed. So we were able to actually partner with Live Stories. Could we get the Live Story up?
Technical issues right before the session. I might have to pull
Okay, well, maybe we may not be able to see the Live Stories version of this, but basically what this is an online live version of the report card that allows us to, because as you saw, there's 7 different source data, and those data sources are updated at different intervals. Some of them it's weekly, some of them it's monthly, yearly, and so there's this dynamic piece to it, whereas if you're just waiting for the PDF, when are you going to update? Is it annual? Then you're missing all those opportunities for closer interval updates. So having a live relationship between an online platform that connects to the data sources directly allows us to kind of have a report card that is always relevant and always accurate. And then it also has certain functionalities around being able to add narrative to the data elements, and even pictures and stories that might bring the data to life. And if that makes sense, that's probably enough. We don't need to see.
We're almost there. Yeah, okay, maybe not. The PowerPoint.
That's right. We'll just go to my last. I'm out of time anyway. You can go to my last slide.
Okay.
So if anyone wants to see this, you can browse rxsafemarin.org, and it has our report card is front and center on that tool, and a lot of the other resources that we're using to share with some of the other counties. So the last, we can just go back to my default presentation. And then the last challenge in terms of data was actually translating what was on that report card into some infographics and using some social math for actually getting it to the end users, which were our elected officials who may not be able to digest that report card level data in a way to actually inform their own sort of policy decision making, and to the community themselves, to our public. So we actually came up with some infographics that were put into some of our social media, using Facebook, using advertising in the newspaper, et cetera. And the example I had here was the amount of one of the big initiatives in the county was helping people dispose of unused and unwanted medications. And we had an initiative where we were trying to increase the number of pharmacies that would host take-back bins. And so to accompany that, we actually had some infographics around the raw amount of medicines that were being dispensed into our county as a sign of the need for opportunities to dispose of those. And that is right here. There it is. Perfect timing. So there's this is just an example of one of the ways that, having sort of gone through the process of learning where the data sources are, acquiring the data, making it more friendly to users through the Live Stories platform, and then actually translating some of that into some select elements that are put into social media and using some social math. So this is Medicating Marin. The number of people in Marin County, the total number of prescriptions for controlled substances, alarmingly, almost twice as many prescriptions as there are people, which was enough for 60 pills. And thanks to Cures, we were able to actually calculate the number of pills that were dispensed into our community individually. So 60 pills per man, woman, and child in the county, which was enough to medicate someone like around the clock for like 3 weeks for a controlled substance. So that was kind of a way of raising awareness and alarm, community-wide around this issue. And then our goal, one of our SMART goals, to reduce the amount of narcotics prescribed in our county by 15%. So that's how we've used data in RxSafe Marin. Thank you.
Okay. Thank you, Matt. So we're going to go ahead on to our next presenter, Debra, who's going to tell you a little bit about Walk Safe. And good, you need it? You got, all right, ready to go.
So thank you for having me today. It's been a really interesting experience for me. I haven't been to this conference, and I've been, I got here earlier this morning, and I've been thinking about a lot of the data that's been talking about has been at the state level and used at the local level. And so I've been really thinking through about how, at the very, very grassroots, boots on the ground kind of level, how we're using this data to inform our programs and for me, more importantly, about what kind of information we go back and seek from residents who actually live in a community to further illuminate and to point to solutions. I shared with Dr. Smith before we started the session that a lot of times when we meet with residents of a neighborhood and we tell them about their community, about how there's high crime, high diabetes, high obesity, lack of healthy food, they look at us and say, well, duh, tell us something that we don't know. And so I think, for us, we've spent a lot of time trying to use data that's out there, but also bring it to life from the real community perspective. So the Health Education Council, I started the council 25 years ago in response to looking at health disparities and realizing that there are tremendous health disparities amongst different communities based primarily on socioeconomic status and race. And as Dr. Smith was talking about kind of where we've come over the last 25, 30 years, I realized that our work has really evolved and changed as well. We used to think that if we increased awareness and people grew in their knowledge, that essentially that they would change their behavior and lead healthier lives. Well, then, all of a sudden, we start realizing that the Surgeon General's report telling us that tobacco is bad for our health came out over 50 years ago, and we're still working on this. So we certainly have come to realize that the social determinants of health and what drives health, right, is really where people live, work, play, pray, shop, learn, and grow old. So the program that I'm going to talk about is a Walk with Friends program. It was started in South Sacramento, and a little bit of context before I get into some of the specifics. This is a geographic area of what we call the HEAL Zone, Healthy Eating Active Living Zone. It is a 6-year initiative, multi-million-dollar initiative funded by Kaiser Permanente. There are a number of sites in Northern California as well as in Southern California. And it is a place-based model, again, following up on what Dr. Smith said about what we know about how your zip code does determine your health often. And it is a population based on last census of about 13,394 residents. Some of the characteristics of the Valley High Hill Zone community that we've been working with are all of the things that, that we've heard about earlier that influence health and are the social determinants of health. So it was one of Sacramento's highest gang activity, highest gang. It is referred to as a crime hotspot. Guess what? It's also a hotspot for diabetes, obesity, and other chronic conditions, high rates of African American infant mortality. There is an extraordinarily high concentration of what we now call apartment living communities, but multi-unit housing with extremely high turnover, not only of residents, but also landlords. Interestingly, there is vested residence in housing surrounding in areas of the Hill Zone, even though it is primarily low to middle socioeconomic status community, extraordinarily ethnically diverse. The main quarter of the Hill Zone is loaded with fast food outlets and small business. There was no community gathering center or community center per se, and yet there was a number of two really nice parks, park facilities. And what we see as we work in communities is that parks are often a real visual indication of a community's health and well-being, whether that park is frequented a lot, whether or not there's activity going on in that park, whether or not it serves as a community gathering spot. So a little bit about Valley High Park. Our Hill Zone, Healthy Eating Active Zone effort focused in on one of those parks. Since this is a data conference, we kind of use data to inform taking us into this park. We knew that the crossing walk into the park was a high traffic accident area, high speed, lots of traffic citations. There's a threat of youth violence was a significant barrier to increasing community use of the park. There was a lot of physical problems with the park, broken lights, obscured by overgrowth foliage, amenities, signage, and bike parking were missing. And yet this park was a safe passage, if you will, to one of the big elementary schools in the Hill Zone. During one of the walk audits that we did was, which is a resident engagement process of further data collection, there was we took out residents and parents and some students, and we all had our orange vests on, and about 15 or 20 feet in front of this group that we took out with their clipboards to do a walk audit. There was 2 groups of young men that jumped out of these unkept bushes, and there was a shooting in front of the walk audit team. So this really served as a catalyst to really encourage the community and tell them that it was time to take back the park. So the Live Well Valley High Community Committee was formed, and we started by listening to the community to say, what are the real issues? What other information do we need to get? We found that we looked at park usage data, we looked at crime data, the kind of crime that was happening in the park. We looked at truancy and absenteeism of the local schools and realized that we needed to start more programs. We started a summer basketball league with churches. Your payment into the summer basketball league was $10, but if you couldn't afford to pay that $10, you had to pay by walking around the park with your neighbors. We did health fairs, we had church services in the park, and this led to creating the walking group. We had strong partnerships with local faith organizations, law enforcement, business, schools, and others. And we really tried to identify some resident champions who lived in the neighborhood, who wanted to invest in the park, had relationships with residents to start the program. We also invested in some of the structural improvements into the park with our grant funds. We installed a hawk light on that busy street. We got the city to come out and repaint the basketball courts, clean up the missing grass in certain areas. So the Walk with Friends program was born after about 1.5 years of getting folks back into the park and using it. We used the evidence-based approach called Walk with Ease, done by the Arthritis Foundation, which was really intended to reduce pain amongst folks who have arthritis. We really tried to we did this snowball networking. We asked every resident who came to the park to bring 2 or 3 friends out to the park and start the walking club. Strong resident engagement. We also tried to address multiple needs. We tried to address fitness. Obviously, this was an active living initiative, so walking was our attempt at addressing fitness. Fellowship was a big part of it. We know that there was a lack of social cohesion, a lack of community connectedness. People who came out to the walk said, I've lived next to this person for 15 years and I've never met them. And then we also had food. We partnered with the food bank, and so everybody who comes to the walking club gets a free bag of produce. We have since started the program at another park, Mesa Grande Park, in the Killzone, and are also taking this model to the city of Roseville and starting it there as well. So, use of data. As I mentioned earlier, we tried to take what folks knew about the park and bring that to life further. So we, as I mentioned, did a walk audit. We held a lot of neighborhood focus groups. We did key informant interviews. We used community hospital needs assessment data, and park usage, et cetera. We tracked the number of people coming. On average, this program's been going on for 1.5 years now in one park, and for 6 months in the other park. We have about 50 to 60 regular walkers who come out when it's raining, like thankfully it was this last couple of weeks. The local church opens up their doors so that the schedule can continue. We've done a lot of participant surveys to continue to gather input about how people feel about the walking club, if it's created new relationships, how do we get more people involved, and it has really contributed to social cohesion. And also, one of the other great things that happens, it's built relationships with city government and with law enforcement. Our park usage increased over the 2 years by almost 300%. And our crime data within the park went down dramatically. So I just wanted to say that, throughout the day, we've been talking a lot about silos, getting out of our silos, silo busting, de-siloing. And I just want to say that that's really, really true at the very grassroots and community level, too. We've had to work differently. We've had to engage residents on their own terms. Sacramento Police Department was a really key partner of ours. There was a lot of mistrust between community and police. We have business around the table, schools, parks and rec, and we have really had to spend a lot of time building relationships and trust to de-silo our work. Thank you.
Thank you, Deborah. I love the part about we told them about their neighborhood, and they said, well, duh. I can relate to that. That's exactly the reaction we always get. We think we're bringing great value, and they're like, yeah, we know. So Dr. Handler from Orange County, WasteNotOC, multiple award-winning program. There you go.
Good afternoon. Can you all hear me? Okay, how many here wondered when they saw all those meals on the table out there, what was going to happen with leftover meals? Raise your hand. Well, guess what? They're donating them. Very simply. And the reason I'm telling you this is I'm going to share with you our program that can be replicated anywhere. And our program is to end hunger in Orange County. That's simple. So if we can get the first slide. I hope this doesn't count against my time. All right, so let's, while we're waiting for that, let me share something with you. I was actually in Sacramento about 2.5 years ago, and I bumped into the director of the OC Food Bank, and I asked him 2 questions. And I'm going to ask you the 2 questions. You tell me what the answer was. First question, do you have enough food in the food bank? What was the answer? Boy, that was great. And if we captured all the food that was thrown out, could we end hunger in Orange County? What was the answer? So I looked at him and I go, why aren't we doing it? You can have all the big data, you can have all the interoperability, you can have all the technology, but if you don't focus on the social determinants of health, you're not going to handle the overall care of that family and that individual. Plain and simple. So I went back to my boss and I said, I want to end hunger in Orange County. He patted me on the shoulder and he says, good luck to you. True story. But here's the message. There is nothing new about poverty. What is new is that we now have the techniques and the resources to get rid of poverty. The real question is whether we have the will, and I'm going to add the passion. If you have the will and the passion, you can solve any problem. And I have to tell you, our program is solving and ending hunger. Next, could you please? Thank you. So this is our website, WasteNotOC. WasteNotOC.org. Everything that I'm going to share with you right now was done with very minimal funding. Very minimal funding. So anybody can do this. Next, please. Orange County. These statistics just blew me out of the water. 12.7% of households are food insecure. They don't know where their next meal is going to come from. 350,000 people in Orange County don't know where their next meal. And here's the kicker. 1 out of 5 children. We are ranked one of the top 10 counties in the nation with the highest number of people facing food insecurity. Orange County. Who would have figured? So you have the best of both worlds. You've got the very rich and you've got the very poor. Next, please. There is the child poverty rates in California counties. So those from California, take a look at this. Orange County's child poverty rate is 18.4%. These statistics are just unbelievable. Los Angeles is 26.3%. Sacramento, 25.2%. You can ignore it, but you can't hide from it. These are the facts. Next, please. So here's what makes our program so unique. The health officer and the environmental health specialists, who are the ones that do the restaurant inspections, are talking and educating restaurants and grocery stores that it's okay to donate food. That's critical. The second part is we are now having our hospitals and family resource centers throughout Orange County to start asking 2 questions about food insecurity. If they answer yes, we then refer them to the nearest pantry. It's a very simple formula. When people were asked why they were not donating food, they gave 2 answers. 2 answers. Liability, and the health department wouldn't let us do it. So if you go to our website, we have a video of the food safety environmental health specialist who says it's okay to donate food because of the Good Samaritan Act. You're not held liable. You're simply not held liable. And if a restaurant or grocery store does donate, we have a seal that they can put in their window saying that they are a supporter of the healthcare agency. That seal was actually created pro bono by a graphic design place. Next, please. Look what we've been able to accomplish since last year. A coalition of dedicated, passionate people, we've been able to get 253 tons of food donated that would have been thrown out. Look at that number. What can one person who says, I'm going to end hunger, who am I to say that I can do that? But it takes one person to bring another person to bring another person to develop a core or a coalition of passionate people that say this is not satisfactory. We need to stop this. We need to end this, and we're going to do it. That's equivalent of 390,000 meals we've been able to generate since last year. Next, please. This is the 2 questions. Within the past 12 months, we worried whether our food would run out before we got money to buy more. And within the past 12 months, the food we bought just didn't last and we didn't have money to get more. I presented this to the American Academy of Pediatrics as a resolution, and it was adopted as one of the top 10 resolutions saying that healthcare providers and healthcare professionals need to ask these 2 questions. As a pediatrician, I never, ever asked that. There are 16 million people in the United States, children, who are facing food insecurity, and I never, ever asked that question. It's now been adopted. The American Academy of Pediatrics says this is a policy. Children's Hospital of Orange County has screened 30,000 families so far. Everybody who is admitted is asked that question. I took a tour of the cancer center at UCI, the Child Cancer Center. At the end of the tour, I said, do you think cancer patients suffer from food insecurity? The executive director said, yes. He said, so I said, we can have 2 questions where we can assess that. And the person said, done. They are now asking the 2 questions. Next. If they answer yes, I had a student work with me. He calls me into his office and he said, Dr. Handler, look what I created. A Google map of all the food pantries in Orange County. Talk about technology. Simple technology. 240 pantries in Orange County. You click on any one of them, and that's the information you get. You put in your zip code, and it tells you the nearest pantry to your location. So if any family answers yes to the food insecurity, you put your zip code in, and it tells you the nearest pantry. And what's really interesting about this is it's been adopted and incorporated into 211OC. So now we're not only looking at social determinants of unemployment and housing, we're looking at hunger. They've taken our map and incorporated, so if anybody goes on their website or calls, they can say this is the nearest place to get the food. So it's 3 things. We're increasing the food supply in Orange County, we're identifying people in need and getting them to the source. How simple a formula is that? Next, please. So, to conclude, I'd like to say that we have now gotten national recognition for our campaign. I'm probably speaking on this at least once a week to different groups. I'm going to be down in San Diego twice. San Diego, LA County, San Bernardino, Alameda, Sacramento, all want to duplicate what we are doing. And they can do it. But again, remember the formula is to have passionate people and have your health officer and environmental health specialist champion this and bring a coalition together to address this critical issue. So thank you.